Welcome to Pulse and Pressors, where critical care becomes crystal clear. Today we'll discuss Milrinone, a powerful inodilator that plays a crucial role in managing acute heart failure and cardiogenic shock. Let's explore how this phosphodiesterase 3 or PDE3 inhibitor enhances cardiac performance and systemic circulation. Milrinone is a PDE3 inhibitor that increases cardiac contractility while reducing vascular resistance. It's both an inotrope and a vasodilator, making it particularly useful in acute decompensated heart failure or cardiogenic shock. Because it both strengthens the pump and relaxes the vessels, we call it an inodilator. To understand how Milrinone works, we need to talk about the PDE3 enzyme. PDE3 is responsible for breaking down cyclic AMP, or CAMP, inside cardiac and vascular smooth muscle cells. When PDE3 is active, it reduces CAMP, meaning less calcium for contraction in the heart and tighter tone in the vessels. Milrinone inhibits this enzyme, preventing CAMP breakdown. This leads to more calcium in cardiac cells for stronger contraction and less calcium in vascular smooth muscle for relaxation. In short, PDE3 acts like a brake on heart performance, and Milrinone releases that brake. Mechanistically, Milrinone inhibits PDE3, causing intracellular CAMP levels to rise. Increased CAMP enhances calcium influx into cardiac myocytes, boosting contractility. Meanwhile, increased CAMP in smooth muscle cells lowers calcium entry, promoting vasodilation. The combined effect is improved cardiac output and reduced systemic vascular resistance. Hemodynamically, Milrinone increases contractility and cardiac output, lowers preload through venodilation, and reduces afterload by relaxing arterial tone. The end result is a more efficient forward flow, the hallmark of effective inotropy combined with vasodilation. Clinically, Milrinone is indicated for acute decompensated heart failure, especially when beta blockers limit the response to dobutamine. Milrinone has a mechanism of action that is independent of beta-adrenergic receptors, unlike dobutamine, a beta agonist. This means its positive inotropic and vasodilatory effects are maintained even in the presence of chronic beta blocker therapy, making it a preferred agent in this scenario. It's also used in cardiogenic shock with high afterload, post-cardiac surgery low output syndrome, right ventricular failure with pulmonary hypertension, and as a temporary bridge to transplant or recovery. Contraindications include severe hypotension, since Milrinone can worsen vasodilation, and fixed outflow obstructions such as aortic or pulmonic stenosis. It must be dose-adjusted in renal impairment. Chronic use is associated with increased mortality and heart failure, so it's limited to short-term use only. Continuous monitoring for blood pressure and arrhythmias is essential. Let's focus on the critical pharmacokinetic profile of Milrinone, which heavily influences our management strategy in the ICU. Milrinone has an elimination half-life of approximately 2 to 3 hours. The pros of this half-life lie in the drug's offset. If a patient develops a severe adverse event, such as profound hypotension or a dangerous arrhythmia, stopping the infusion allows the drug concentration to fall by 50% in 2 to 3 hours. It will take approximately 10 to 15 hours, about 5 half-lives, to achieve near total clearance, meaning less than 5% of the drug remains. The cons are highly relative in the ICU. Compared to other common vasoactive drips like norepinephrine, dopamine, or dobutamine, which often have half-lives measured in mere minutes, Milrinone's offset is significantly slower. While the short half-life is a pro compared to a drug with a 24-hour half-life, it is a major con relative to catecholamines, making Milrinone far less titratable for rapid blood pressure management. This slow offset also affects our loading dose strategy. Without a loading dose, Milrinone would take 8 to 18 hours to reach therapeutic steady-state levels. This prolonged time to onset, combined with its poor titratability, makes the immediate administration of a loading dose crucial in the critically ill to achieve the desired hemodynamic support quickly. Finally, regarding discontinuation effects, its long half-life means we can't simply turn it off. Instead, Milrinone's effects will dissipate slowly over several hours, necessitating a careful, gradual taper and vigilant monitoring to avoid a catastrophic rebound worsening of cardiac function as the remaining drug is slowly cleared. One key advantage of Milrinone is that it doesn't depend on beta-receptor activity. This makes it effective in patients who are beta-blocked. However, because of its pro-arrhythmic and vasodilatory effects, patients should always be closely monitored. Think of Milrinone as a short-term rescue, not a long-term solution. In summary, Milrinone inhibits PDE3, raises CAMP, increases contractility, and decreases afterload. It improves forward cardiac output while reducing filling pressures, a valuable tool for managing decompensated heart failure under careful supervision. This is Pulse and Pressers, providing daily education on the marvels of the human body.